So my name is Megan Carmelani. I am the founder and president of Long COVID Families. We are a nonprofit that supports children and caregivers with long COVID. I am here today to talk to you about impediments to care specific to the pediatric community. I do not have long COVID myself. However, I do have post-viral syndromes that are anchored in an infection I had as a child, leaving me with symptoms almost identical to many children with long COVID. Symptoms I still have today. It took me almost 30 years to receive an appropriate diagnosis and medical care. I do not want that for any other child, which is why I'm here today. Unfortunately, the barriers to medical care I experienced as a child are still present. Long COVID is an invisible illness for the most part. Standard medical tests do not tell us much. Therefore, the primary source of information is the patient themselves. This means the patient's ability to articulate the internal workings of their body is essential for treatment. This puts children at a disadvantage as they typically do not have the language of illness, or they are pre-verbal, and some are nonverbal. They usually do not know how to interpret these strange new body sensations. For example, I was first diagnosed with mono when I was 11, after which I had a sensation in my chest that I struggled to describe. I repeatedly told adults I can't breathe, and I was told it was anxiety. So I stopped telling anyone what I was experiencing. I continued to have that sensation in my chest to this very day. Turns out that sensation is tachycardia, which I learned when I was 39. Kids with long COVID often describe tachycardia in the same way. They will say, I can't breathe. Other things kids have said, my throat hurts, when they mean their necks. They'll say, I can't think, when describing cognitive dysfunction, or sometimes they'll say their head hurts when they mean they're struggling to process new information. One of the hallmark symptoms of post-viral illness, including long COVID, is fatigue, which is also one of the hardest symptoms to identify in vocabulary. They might say they're tired or they don't want to do something. It can be as confusing to the child as the parent. And typically it's contributed to lifestyle, such as sleep or diet. In addition, children struggle to communicate the impact of fatigue on their daily lives. This is because they lack the lived experience to have a clear sense of before and after, which is what many adults rely on to explain debilitating fatigue. For instance, you may hear an adult say, I used to be able to work a 12-hour shift, and now I struggle going to the grocery store. What's interesting is that we've noticed that athletes seem to be diagnosed quicker than the average child. And that may be because the symptoms are easier to identify. As one teenager said, I used to run the stairs at school, and now I can't even walk 3 steps without feeling like I need to sit down. So there's a clear before and after that can be observed by adults. The observation of symptoms by adults is vital when it comes to recognizing long COVID in kids. They need an adult to truly see their struggle. If that doesn't happen, then that is an insurmountable obstacle to medical care. Kids can't take themselves to the doctor. It will often take a caregiver more than 6 months, often 9 months, to recognize long COVID. Sometimes it's taken more than a year, which begs the question, how many kids are we missing? Once a caregiver recognizes the symptoms, there's yet another obstacle. The caregiver has to explain it to the doctor in a way the doctor can receive. Parents will often say things like, my child is just not behaving like himself, or my child spends all her time in her room. This is not enough information in a 15-minute office visit for the doctor to figure out it's long COVID. Additionally, even if the parent clearly explains the child's symptoms, diagnosis still requires the doctor to be knowledgeable enough about long COVID and post-viral illness to recognize the pattern of symptoms to inform proper course of action. I want to go back to my story for a moment to demonstrate how easily these symptoms can be missed. Again, I was 11 when I was diagnosed with mono. Months later, I noticed I couldn't run as fast in soccer, and I often felt lightheaded and dizzy. I was told I was dehydrated. I would nap after every game. I was told that was because I was growing. Soon after, I quit soccer, unable to keep up with my peers. My parents thought I had just lost interest. I now know those were symptoms of POTS, which is a dysfunction of the autonomic nervous system, and post-exertion malaise, one of the hallmarks of ME. I had serious digestive issues. I was told IBS and hormones were to blame. At 39, those symptoms finally resolved after I started taking medication used for mast cell activation syndrome. I had pain in my legs. I was told that was due to growing pains. I now know this is a common way for kids to express fatigue or even blood pooling in the legs, which is a symptom of POTS caused by blood vessels not constricting properly. So you can see how easy it is to miss these significant symptoms. As a child, I had no other choice but to push through. I progressively got worse over the years. By the time I was in my 30s, I was no longer able to work, and I spent 3 years essentially bedbound. Countless doctors were unable to help until I met one who had a significantly different approach. More tests were run, and once again, results were within normal range. I expected the doctor to say there was nothing else we can do, as all the others had. Instead, this doctor pulled up a chair and asked me a series of questions. When, where, how do you experience your symptoms? There was something in my answer that made her eyes light up. She grabbed a piece of paper, wrote down instructions for me to record my blood pressure and my heart rate. She handed me the paper, told me to buy a blood pressure cuff, and come back in a week with my heart rate and blood pressure numbers. Without fully explaining, she was directing me to do what is known as the NASA 10-minute lean test. A week later, I brought my numbers in. They were all over the place. She looked over the paper and announced, well, it looks like you have POTS, which was a medical condition I had never heard of. I was then referred to a dysautonomia clinic for further testing and encountered another doctor with a unique approach. After the doctor introduced himself to me, he took out a pad of paper and he said, tell me about your symptoms. Start with the first time you noticed them or that something was off. And then he listened intently as I told my story, beginning when I was 11. He asked me questions in an effort to identify a pattern. Within the week, I had multiple new diagnoses, new symptom management strategies, and medication. Within a month, I was able to get out of bed most days. It was like someone flipped a switch. That was only 4 years ago. I am still disabled, but treatment took away my suffering. I take the lessons I learned from those two doctors and I share it with the caregivers today. The context of the symptoms matter. The frequency, the severity, and duration. In order to capture this information, I suggest that caregivers develop scientific observational skills, which is to observe using the 5 senses and document those observations. For instance, what do you see when you look at your child's skin? What do you see when you observe them doing homework or eating, when they are sitting, standing, walking, climbing stairs? What do you notice about your child's sense of sight, sense of smell, sense of taste? I suggest caregivers document these observations over the course of 3 weeks and bring these observations to the doctor. And for parents who have tried this, it's been a very successful strategy. So that's what we can do as caregivers to help children with long COVID. We can truly see them. What pediatricians can do is to understand that long COVID in kids typically shows up as syndromes, which means the pattern of symptoms is important. It's also important for the doctor to look at co-occurring symptoms and to know symptoms are typically waning and reoccurring. We need doctors who are familiar with common comorbid post-viral syndromes and are able to identify the evidence of illness in a patient's story. In addition, we need doctors to be open to noticing new patterns that might be unique to long COVID. And finally, we are seeing organ damage in some children post-COVID that is not apparent on standard testing. For instance, some of our children have lung damage that only showed up on SPECT imaging. All of these children were initially told that they had exercise-induced asthma, and it took more than a year of reporting symptoms for lung damage to be found. We have also heard reports in our patient forum of liver, heart, and kidney damage. I have no way of knowing how often this happens or if COVID is fully or partially to blame. I simply know it's happening, and we need to look into it. Thank you for your time.
Again, and thank you for sharing that that journey you've been on and giving back to others. Your organization does so much to help so many. We're so grateful.